Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A patient scheduled for bariatric surgery is referred for further preoperative medical evaluation due to the unexpected finding of transaminitis on preoperative laboratory tests. Which of the following findings is least likely to be associated with elevated perioperative mortality? A. Acute hepatitis B infection. B. Acute alcoholic hepatitis. C. Chronic hepatitis C infection. D. Child's Charcot-Pugh class B cirrhosis. And E. Cirrhosis with a MELD score of 12. And the answer is C, chronic hepatitis C. Acute hepatitis, whether due to viral infection or alcohol abuse, is associated with a high perioperative mortality rates and is a contraindication to elective surgery. Cirrhosis also increases perioperative mortality, with the risk proportional to the severity of cirrhosis as measured by Child's Charcot-Pugh classification or the MELD score. Chronic viral hepatitis, in the absence of cirrhosis, does not substantially raise risk. Preoperative evaluation of patients with liver disease. Surgery in patients with serious liver disease is associated with higher rates of hemorrhage, infection, renal failure, and encephalopathy, and overall mortality. Observational studies have found a high mortality rate when patients with acute viral hepatitis undergo abdominal surgery. Acute alcoholic hepatitis also substantially increases risk. Thus, elective surgery is contraindicated in patients with acute viral or alcoholic hepatitis. Chronic viral hepatitis poses a much lower risk, which is proportional to the severity of any resulting cirrhosis. Non-alcoholic fatty liver disease, in the absence of cirrhosis, is also unlikely to substantially increase perioperative mortality. Cirrhosis is associated with a higher postoperative mortality. The risk correlates with the severity of liver dysfunction. The Child's Charcot-Pugh classification system for cirrhosis, or the model for end-stage liver disease, that is the MELD score, can be used to predict postoperative mortality. Child's Charcot-Pugh class C cirrhosis is associated with mortality rates in excess of 50% following abdominal surgery and is thus considered to be a strong contraindication to elective surgery. Patients with class B cirrhosis are also at increased risk, and surgery in these patients should be pursued with caution. MELD score less than 10 are associated with generally good outcomes after surgery, whereas scores greater than 15 predict a very high risk. Keys to history and physical examination. Findings in the history that suggest a higher risk of liver disease, including heavy alcohol consumption or high risk behaviors for contracting hepatitis B or C, should prompt more detailed investigation. The physical examination should look for signs of cirrhosis such as jaundice or spider angiomata. Calculation of the Child's Charcot-Pugh score also requires examining the patient for the presence and severity of hepatic encephalopathy and ascites. Diagnostic testing. Routine preoperative measurement of liver enzymes has very low yield and should be reserved for patients with known or suspected hepatic disease. In patients with cirrhosis, the total bilirubin, albumin, and prothrombin time should be measured to calculate the child's Pew-Turcotte score. Calculation of the MELD score requires measurement of total bilirubin, prothrombin time, and creatinine. Preoperative imaging studies are not routinely needed. However, in patients with suspected ascites, abdominal ultrasonography can quantify the amount of ascites and assist with its management. Risk reduction strategies in liver disease. Patients with cirrhosis should be at their optimal baseline status prior to elective surgery. The strategies to achieve this are the same as for non-surgical patients. Patients with coagulopathy may benefit from oral vitamin K prior to surgery, but may still need replacement of clotting factors intraoperatively. Ascites should be minimized with diuretics, time permitting, or paracentesis. Renal function and volume status should be monitored closely in the perioperative period, and electrolyte abnormalities should be corrected. Minimizing the use of psychoactive medication, especially those that are cleared by the liver, may reduce the risk of hepatic encephalopathy. Patients already on medications for encephalopathy should continue them, but it is not necessary to start such medications just because of a planned operation. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's Textbook of Internal Medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service, and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.